for coming today. We appreciate it. We'll get right to it. We've still finishing up a lot of work this week, and we've still got, what day? Oh, Wednesday, because we're wearing these jackets, so we still have 2 days left to go. Okay. With that, I'll open the hearing on House Bill 2386. Carly, if you'll give us an overview.
Thank you, Mr. Chair. Good afternoon, committee. House Bill 2386 updates the eligibility requirements for the state children's health insurance program. Section 1 amends KSA 38-2001 to remove language in subsection B7 regarding the federal poverty income guidelines for 2008. Section 1 also removes subsection B8 regarding a waiting period for newly enrolled participants with a family income over 200% of the federal poverty income guidelines. Finally, Section 1 removes subsection E, which deems a child ineligible for coverage and would lose such coverage under the plan if the child's family has not paid the applicable share of any premium that is due. House Bill 2386 would take effect on July 1st, 2025 upon publication in the statute book.
Committee questions on the bill? Seeing none? You did a great job, Carly. Okay, next, first proponent is Yvonne. Yvonne, good to see you again.
Nice to see you, Representative Carpenter. Yvonne Case, Director of Operations for Medicaid, here to testify on behalf. We're in favor of this bill. So when it was originally in 2008, there was a bill passed that tied the rate for this CHIP premium to the poverty level, but it tied it to the poverty level at that time in 2018, and it stayed there. And every year you passed a proviso to bring it current, and that's what this bill will do. It'll make that permanent. So we're in favor. And then the other two pieces of the bill that she mentioned about the non-payment of premiums and the waiting period are unenforceable because of federal legislation that has been passed since. And so it will simply put the state in alignment. Nothing will change as far as the way we're operating. So we're in favor. I'll entertain any questions.
Very good. Questions of Yvonne? Seeing none.
Thank you.
There should be a special place in testimony for Heather. But I'm going to let her deal with that. Heather, welcome to committee.
Thank you, Mr.
And you know what I'm talking about exactly.
I know exactly what you're talking about. Thank you, Mr. Chair and members of the committee. I'm Heather Brom, Senior Policy Advisor with Kansas Action for Children, and thank you for the opportunity to provide testimony in strong support of HB 2386, which permanently makes changes to the Children's Health Insurance Program, or CHIP statute, including fixing a nearly 17-year-old issue with eligibility levels. Honestly, the error is now so old, it soon will not be eligible for CHIP itself based on age, but I digress. Kids' health depends on regular access to quality care, which includes health insurance coverage, covering important time-sensitive services like doctor and dentist visits, immunizations, therapies, prescriptions, and hospital stays. Up to a certain income limit, CHIP coverage is available for children in Kansas families whose household income is too high to qualify for Medicaid and who aren't offered child insurance coverage through a job, or they can't afford health insurance for their children on their own. The program is succeeding in connecting eligible kids to coverage, but there's a problem, as you've already heard. According to state law, Kansas kids can qualify for CHIP if their family's income is less than 250% of the 2008 federal poverty level. When CHIP was last significantly updated in 2008, the legislature accidentally pegged eligibility back to that 2008 federal poverty level in statute. As a result, through early 2022, the state had to annually convert the eligibility level back to those 2008 numbers. The converted percentage had declined to 225% by 2021. You can find a chart of that erosion in our written testimony and see the explanation for why we call this an error. Since 2022, and this is what the chair was hinting at, the legislature has passed several annual budget provisos temporarily ignoring that 2008 year reference in state law, but a permanent fix continues to still be needed, which is what this bill does. It also removes 2 additional clauses in the statute that are out of alignment with federal regulation to the CHIP program. These are collectively known as waiting period and lockout periods, which are no longer allowed under federal regulation, and removing this language eliminates some confusing barriers that may prevent eligible children from receiving their CHIP coverage. While this bill may seem like a simple and technical fix, we have learned over the last 4 years advocating for this bill's permanent fix, along with the budget provisos' temporary fixes, which we thank the chair for his annual support of those provisos, that nothing is ever easy or simple, but we are hopeful that 2025 is the year that we get the CHIP eligibility fix across the finish line and the necessary changes permanently made to state law. CHIP has connected thousands of Kansas kids to insurance coverage over the past 27 years. We urge this committee's support of House Bill 2386, guaranteeing more Kansas kids continue to have insurance coverage in our state. Thank you, and I'll stand for questions at the appropriate time.
Very good, Heather. Thank you for that. Committee questions? I just have one. What is the federal poverty level now for, it might be in your testimony, but I didn't bring my computer today because I usually don't have time to open it anyway. Say, a family of 6.
I can't tell you the family of 6 unless I grab my phone and I can quickly look it up.
Oh,
I
that's
can
right.
tell you family of 4 ballpark. This isn't the exact dollar amount. Ballpark, it's about $80,000
Okay.
for a family of 4.
So 6 would be upwards of 100,000.
6 would be
Yeah.
above that.
Yeah, so
Yeah.
federal poverty level and eligibility for CHIPS for a family of 4 now is $80,000.
For Kansas is 250%.
Right.
Yes.
At the 250%. Okay, very good. Committee, any other discussion? Very good. Thank you very much for
Thank
being
you.
here. Okay, next we'll close that hearing and we'll open the hearing on SB 126, enacting Physician's Assistant Licensure Compact. Carly? Thank you.
Thank you, Mr. Chair. Committee, this is a mirror of House Bill 2219 and also includes the technical amendments that the committee made at that time. So Senate Bill 126, as amended by Senate Committee, enacts the Physician Assistant Licensure Compact to provide interstate practice privileges for physician assistants. Section 1 states the purpose of the compact. Section 2 provides definitions used in the compact. Section 3 sets out the criteria for states to participate in the compact. Section 4 sets out the criteria for physician assistants to receive a multi-state license. Section 5 requires a licensee, when applying for a compact privilege, to identify the participating state from which the licensee is applying. Section 6 permits a participating state to impose adverse action against a licensee in that state. Section 7 provides for the establishment and operation of the PA Licensure Compact Commission. Section 8 requires the commission to develop and use a coordinated data and reporting system containing license and adverse action information on licensed PAs. Section 9 requires that the commission adopt rules and regulations to implement and administer the provisions of the compact. Section 10 sets out the rules for oversight, dispute resolution, and enforcement of the compact. Section 11 states that the effective date of the commission is upon the passage of the 7th member state. Section 12 contains a severability clause. Section 13 provides that nothing in this compact is to prevent or inhibit the enforcement of any other law or regulation in a participating state. The bill passed the Senate by a vote of 39-1, and it would go into effect on July 1st, 2025. And I can stand for questions.
Any questions? Thank you very much, Carly. And committee, I might back up here just a little bit. There's written only on the previous bill, the CHIPS bill, written proponent testimony from Aaron Dunkel, Charlie Hunt, Dr. Dina Hubbard, Brenda Sharp, and Tanya Dorfbrenner. So bring your attention to that. Okay, we have the first proponent for this bill. You guys could just tape your answers from before and play them. Michelle, and she's virtual. Michelle, are you there?
Can you hear
This
me?
is our 5th compact bill this year, I think, something like that. So, Michelle, welcome to committee. Can you hear us?
I can. Can you hear me, sir?
Yes, we can.
Thank you. Chairman and honorable committee members, it's great to be back in front of this committee again. My name is Michelle Richard, and I am the Midwest Region Liaison with the United States Department of Defense, specifically the State Liaison Office. We operate under the direction of the Undersecretary of Defense for Personnel and Readiness. We stand in support of the Physician Assistant Compact and the policies reflected in Senate Bill 126. This proposed policy change addresses licensing issues affecting our service members and their families. Licensure issues for both our transitioning military members and their spouses have been a priority for the department for several years. Occupational licensure compacts provide consistent rules that allow licensed members to work in other states through privilege to practice policies or to transfer their licenses more easily to a new state. Military provisions added to these compacts assist military members and their spouses to participate in these compacts. As our military members and their families move from state to state, obtaining licenses for employment is very important. Military spouse employment is approximately 21%, which is much higher than the national average. These compacts serve to relieve one of the many stressors of a military move and support military families' financial and personal well-being. In addition, they add to the mission readiness and resiliency of our armed forces. We are grateful for the tremendous effort that Kansas has historically made to support our military members and their families and appreciate the opportunity to support these policies. Again, thank you for your support on this issue, and I stand by for any questions that you may have.
Thank you, Michelle. Committee, questions of Michelle? Seeing none, thank you. Next, we have Lieutenant Colonel Keith Marshall. Thank you very much for being here.
Good afternoon, Mr. Chairman, members of the committee. Lieutenant Colonel Keith Marshall with the Kansas Adjutant General's Department here on another licensing compact bill. So my testimony doesn't change between bills because we're not subject matter expertise in the specialties of the bills. Rather, here supporting this is a good piece of legislation for military families and spouses. So this legislation is a result of a law that Congress passed in 2023 called the Military Spouse Licensing Relief Act, and that act intended to provide licensure portability across all 50 states for military spouses and military families. So as you consider this extension of that and alongside the other, I think, 4 compact bills that we've heard this year, we just appreciate your support for military families and urge you to support this bill. Thank you, Mr. Chairman. I'll stand for questions at the appropriate time.
Thank you very much. Committee questions? Seeing none, thank you very much.
Thank you.
Next, we have Doug Smith, Executive Director, Kansas Academy of Physicians Assistants. Doug, welcome to committee.
Members of the committee, Doug Smith on behalf of the Kansas Academy of PAs. I'll be very brief. You've already heard about this. Your body took unanimous action on the floor when you took up your version of the bill. We would just encourage you to take the same action on this Senate version. I do want to reiterate that the bill does not expand the scope of practice for PAs. It still allows the state regulatory authority over licensees. And only qualified PAs who meet certain conditions are eligible for this compact privilege. And so I'd stand for questions at the appropriate time.
Committee questions? Seeing none, thank you.
Thank you.
Next, we have William Witt. William, welcome to committee.
Good afternoon, Mr. Chairman, members of the committee. William Wilk, Senior Director of Government Affairs for the Kansas Chamber. I'm here to testify in support of Senate Bill 126. It's a compact bill. These issues came through our Military and Veteran Affairs Council. Just would urge your support for this bill, and we do appreciate the committee's efforts to hear these compact bills and get them out quickly through the legislative process. So with that, I'm happy to stand for questions.
Very good. Committee questions? Seeing none. Thank you. Okay, committee, I'll bring your attention to written-only proponent testimony, Katrina Abram and Michelle Kelly. And I think that's it. Okay, I'm going to close the hearing on Senate Bill 126, and we'll open the hearing on House Bill 2250. Carly?
Thank you, Mr. Chair. Committee, House Bill 2250 increases the annual assessment rate imposed on hospital providers. Section 1 amends KSA 656208 to increase the annual assessment on services provided by hospital providers to an amount not greater than 6% of each hospital's net inpatient and outpatient operating revenue. Section 2 amends KSA 656209 to provide that critical access hospitals or a rural emergency hospital with revenues below the threshold determined by the Healthcare Access Improvement Panel is exempt from the assessment imposed by 656208. Section 3 amends KSA 656210 to provide for payments made under KSA 656208 due and payable in equal installments on or before May 30th and November 30th. Section 3 also authorizes the Department of Health and Environment to take legal action against any hospital that fails to pay the amount due upon recommendation from the Healthcare Access Improvement Program Panel unless such hospital has established and is compliant with a department-approved payment schedule. House Bill 2250 would take effect on July 1st, 2025 upon publication in the statute book.
Committee questions? Seeing none, very good. The first and only proponent we have is Audrey Dunkel. Audrey, welcome to committee. Try explaining this to us.
You got it. Thank you, Mr. Chairman, members of the committee. My name is Audrey Dunkel, and I'm the Vice President for Medicaid and Legal Affairs at the Kansas Hospital Association. We appreciate the opportunity to talk to you about why we support House Bill 2250. One thing to note is this program's been around for 20 years, hasn't had significant changes except to increase the revenue for the program. As our Medicaid program has grown, additional revenues were necessary. House Bill 2250, however, does make a significant change by adding critical access hospitals to this program. Currently, the program taxes only non-critical access and non-rural emergency hospitals, but everyone, all hospitals, benefit from those additional dollars. We don't make this request lightly. We did convene a group of our hospitals to discuss going to the 6% rate, as was included in your budget bill. That group did include critical access and rural emergency hospitals. And in fact, that group said, wait, we need to step back. We need to pull more of our critical access and rural emergency hospitals in, and they need to make the final decision about whether or not they will be paying this tax. That group got together, reviewed the impact for all critical access hospitals, and came up with what you have before you, which is a process that determines there is a threshold where critical access and REH hospitals wouldn't be able to cash flow the tax, so they would be excluded. Everybody above that threshold then would pay the tax, and all of the revenue generated by the critical access and REH hospitals would go to those hospitals. Are there any questions, Mr. Chairman?
Committee questions? Representative Ellis.
I apologize for being so dense. So you say they're going to tax the hospitals and give the money back to them?
Yes, so let's talk about how that works. So the assessment on the hospitals is paid to the state, goes into a special fund that is the HCAP fund. It's then used to match federal Medicaid dollars. So since our Medicaid match is about 61%, it more than doubles the revenue that's available. That's then redistributed to hospitals based on their Medicaid claims. So it enhances Medicaid payments.
I like that.
Yes. Yes, no state general fund included in this, but it is an opportunity to maximize our federal dollars.
That will help my little hospital.
Yes, sir.
Thank you, Mr. Chairman.
Thank you. And it has helped your little hospital for quite some time. I think I carried the first bill, it was 1.8 on it was only outpatient, I think.
Inpatient.
And so then the next time we added inpatient and outpatient
Yes,
and
sir.
3%. And at this rate, I'm testifying here a little bit, but I think the committee should know this. So last year, in 2023, the provider assessment was $177 million. And it brought down $340 million worth of federal funds to be spread out among all of our hospitals. 2024, 184 million, 196 million spread out among all the hospitals. And then last year, or this year, 2025, which is kind of this year, 190 million, 305. And then with this increase up to 6% should bring home another almost $200 million. And then if the critical access hospitals and the RAH hospitals come on, it's another 58 million. So this is serious money that has helped our our hospitals, period, and our rural hospitals big time. So anyway, sorry about stealing some of your thunder.
Well done, sir.
This is something that I know just a little bit about.
Yes, sir.
So, committee, further questions? Representative Weichel.
Thank you, Mr. Chairman, and thank you, Ms. Dunkel, for being here. It's great. I love the provider tax. As the chairman explained, does great things for our hospitals. Am I correct that it is under threat in Congress right now? Are you concerned about that?
So interesting question. I believe what you're referencing, and there was a study done, I believe it's dated December of 2024, talking about, hey, if we're going to make reductions to the budget, and obviously the budget is the big discussion in DC, what's the potential for reducing the cap on the assessment rates? Now, the cap on assessment rates is set by statute at 6%. There's certainly some conversation about what happens if that is reduced. We planned for that in this particular legislation because we asked to increase the assessment rate to up to 6% to allow us to maximize whatever we can above the 3%, depending on what happens in DC. So do we know what's going to happen? No, you've been watching it as much as I have, so I don't think anyone can predict where we will land in this particular case, but we do believe it's important to maximize the dollars available to us wherever that threshold is set.
Representative Ruiz.
Thank you, Mr. Chair. Can you say a little bit again about there's an exclusion somewhere?
Yes.
So I was trying to read it on your testimony and I didn't see it.
Yes.
So I need to write it down.
No problem. So the critical access and rural emergency hospitals with revenue below a set threshold would not pay the tax. Any facility with revenue above that threshold would then pay the assessment. Now, important to note that as we've done our initial estimates, and again, we use the best information available, but by the time this gets approved, this number may be different. That threshold, we think, is about $7 million in revenue. $7 million in revenue, yes. And again, the perspective on that was, what is the threshold that makes this something a critical access or a rural emergency hospital can cash flow the tax payments? And I do have to give some real credit to our friends at KDHE who have worked with a number of our hospitals to set up payment programs so that they can cash flow, because those two big payments a year, some hospitals struggle with that. And KDHE has always been terrific about working with our hospitals to make sure that works.
Committee, further questions? Seeing none?
Thank you,
Very
Mr.
good.
Chairman.
Thank you. Well, committee, I'll bring your attention to written only proponent testimony, Joel Phelps, Kevin Strecker, Nicole Milo. And I'll close the hearing on 2250 and open the hearing on House Bill 2397. Carly, thank you.
Thank you, Mr. Chair. Committee, House Bill 2397 increases financial assistance for local health departments under certain circumstances. Section 1 amends KSA 65-242 to increase the assistance amount to $12,000 for local health departments that apply for state financial assistance. House Bill 2397 would take effect on July 1st, 2025 upon publication in the statute book, and it can stand for questions.
Committee questions. Representative Opeza.
Thank you, Mr. Chair. Thank you for the presentation, or I'm sorry, the explanation. Can you tell me, it says under certain circumstances, is that listed somewhere?
I don't believe there's a, Mr. Chair, there's not a list in the bill, but I can go back and find them specifically for you and mention them to the committee.
Okay, thank you.
Representative, could you restate your question?
The bill states under certain circumstances. I was wondering if there's like a definition, a list of what under certain circumstances is?
Okay. Just so I was clear. I think it might be if the funding was available is what I think it is.
Okay, so it's not in particular to a certain potential outbreak or need of the,
The way I'm aware of this
Okay.
is just about funding.
oh, just about funding?
Yeah.
Okay, thank you.
Representative Reeves might know. And we've been dealing with this for a long time in social services budget, so. Okay, committee, further questions? Thank you, Carly. Okay, the first proponent we have here is Christy Kane. Christy? Welcome to committee.
Thank you, Chairman Carpenter and honorable committee members. I appreciate the opportunity to provide testimony today for House Bill 2397. I'm the director of the local public health program at the Kansas Department of Health and Environment, and we provide training, technical assistance, funding, and other resources to the 100 local health departments across the state that serve all 105 counties. And part of what we do is to administer the state general funds through the state formula process that's been in place since 1982. The purpose of 2397 is to adjust the statutory formula, which has not been modified since 1992. The minimum in statute is $7,000 per local health department. Currently, 51 of the state's smallest rural and frontier health departments receive the minimum, and 7 more receive just above that minimum. There have been successful provisos obtained since 2021 through last fiscal year, increasing the funding for each local health department to $12,000 annually. It would be more efficient to establish the adjustment as a permanent measure. The existing minimum per health department has proven insufficient to meet community public health needs. Increasing the minimum amount awarded to each local health department helps extend their services to larger segments of the population, as well as allow them to better adapt to changing public health needs and emergencies. Ultimately, increasing the minimum funding amount for local health departments from $7,000 to $12,000 is a strategic investment in community health. This bill has no direct fiscal impact for the state. It simply restructures how the existing funding is awarded. It does have significant fiscal impact for our small rural health departments. Thank you for your time and consideration as we encourage the passage of House Bill 2397, and I'd be happy to stand for questions.
Thank you. Thank you. Any questions? Representative Howell.
Thank you, Chair. Thank you for being here. So as I look at this and read your testimony and listen to your testimony, I think that this is obviously an adjustment needs to be made since it hasn't been made for, I mean, I'm pretty sure we have members here on the committee that may have not even been born yet. So obviously it sounds like a reasonable thing here. I won't look at anyone, okay, or anything, but And obviously, helping some of our rural counties is, of course, a worthy endeavor. But is this balanced also for some of our higher population counties?
It is. So basically, it just maintains the status quo that we were able to achieve through proviso. So the last 3 years, there's been an increase in funding for the state formula funds. There hadn't been an increase since 1992, and so we were graciously able to receive some increased funding. And so the funding with the proviso was done at a $12,000 minimum for all the local health departments. So the large won't see any difference. It would maintain, we're asking for level funding this year, and so it would be the same amount that they received in the past year, if that makes sense. So the budget is a little over $5.6 million, and it's distributed across the 100 local health departments. So there shouldn't be any change to that for this coming fiscal year if the statute or if the bill was adopted. I hope that made sense.
Any further questions? Chrissy, thank you very much for being here.
Thank you.
Next, we have Randy Bowman. Randy, welcome to committee.
Thank you, Mr. Chairman, members of the committee. Again, my name is Randy Bowman. I'm the Executive Director for the Kansas Association of Local Health Departments. And our health department members are the 100 health departments serving 105 counties in this state. So to follow up to Representative Howell's good question, our two largest counties who get the most money are both on our executive board, and this has been part of our platform for several years now to get this done. So I don't anticipate Adrian will give you any concern if you pass this bill. I also to add that Christy covered it well, as did the revisor's office, but really, we've been doing this proviso since 2001. So I think the policy is pretty well accepted by everybody. We really need to move what really, frankly, is tiny money from $7,000 to $12,000. And my plea is let's just get this in statute so we don't have to keep fiddling with it every single year. It just kind of simplifies all the moving parts that are part of the budget process, which you know far better than I do how many moving parts you have there. So let's just get one off the table. Pass this bill would be fantastic and appreciated. And with that, I can stand for any questions.
Very good, Randy. Thank you for that. Committee questions? Seeing none, thank you very much.
Thank you.
Okay, I'll bring your attention written proponent testimony from Heather Braun, Denise James, Shalea Shea, Rebecca Johnson, and Don Jones. And with that, we'll close the hearing on 2398, House Bill 2397, and open the hearing on 2399. Carly?
Thank you, Mr. Chair. Committee House Bill 2299 establishes the Advanced Universal Newborn Screening Program, provides for the reimbursement of certain treatment services, and extends the transfer of monies to the Kansas Newborn Screening Fund. Section 1 amends KSA 65180 to establish an advanced newborn screening program, which would be administered by the Secretary of Health and Environment. This program would carry out an education program, provide recognized screening tests, and a follow-up program for conditions identified by the Secretary. Such program would also maintain a registry of cases to support early diagnosis, treatment, and services, and provide necessary treatment product for diagnosed conditions. Section 1 also provides for the reimbursement of medically necessary food treatment product and creates the option for the department to purchase such food treatment products for distribution. Under subsection I, the Secretary would determine and identify the conditions that would be included on the newborn screening tests, which may include, but is not limited to, the conditions listed in the recommended uniform screening panel issued by the United States Secretary of Health and Human Services. Section 2 amends KSA 65181 to add language referencing the conditions identified by the Secretary of Health and Environment under KSA 65180I, and Section 3 amends KSA 65183 to add language referencing the conditions identified by the Secretary under KSA 65180I. House Bill 2399 would take effect upon publication in the Kansas Register. And I can stand for questions.
Committee questions? Seeing none, thank you very much, Carly. First proponent we have is Drew Duncan. Drew, welcome to committee.
Chairman Carpenter, members of the committee, thank you for the opportunity to appear today and speak on support of House Bill 2399. I am Drew Duncan, the Screening and Surveillance Section Director at the Kansas Department of Health and Environment, which includes our newborn screening programs. As mentioned, House Bill 2399 amends outdated language, establishes a universal screening program, and increases the funding capitation placed on our sole source of funding, the Newborn Screening Fee Fund. The proposed change I want to focus on today is increasing the cap to the fund to ensure resources are available to conduct an effective, quality, and efficient newborn screening program. It is a public health mandated program since 1965 that started with the screening for PKU. It is provided at no cost to families or providers in the state of Kansas. And in 2023, we did nearly above 35,000 screenings, and estimated costs to be anywhere from as low as $60 per screen up to, in some states, $203 per screen as of that data in 2023. In 2012, KSA 65180 was amended, establishing the Newborn Screening Fee Fund. In 2017, it was further amended to place a capitation on the spending for the newborn screening program. However, that capitation was placed, did not reflect an expanded or fully staffed program. As mentioned, we do aim to screen all conditions that are on the recommended uniform screening panel, and which now includes 38 conditions. Kansas screens for 36 of those 38 conditions. We anticipate bringing on the 37th condition this year and follow with the 38th condition in fiscal year 2026. Since 2020, Kansas has added 5 conditions to the newborn screening panel, which was made possible with some non-renewable federal grants, as well as the budget proviso that the legislature has given over the last 5 years. The implementation of an advanced universal newborn screening program provides newborns identified through the newborn screening program with the best chance at healthy development. With the expansion of 5 conditions over the past 5 years and the recommendation for Kansas to remain in alignment with the RUSP, the program will be underfunded under the current statutory capitation. Underfunding could result in a reduction of activities that were made possible due to the budget proviso and limit the ability of newborn screening program to grow as new conditions are added to the RUSP. It is also important to note that it does place a capitation that is not what the expected expenditures are. It just allows the program to spend up to that amount. And I will now stand for questions.
Committee questions? Representative Reeves.
Thank you for the explanation. You've talked about the cap, and so the current cap is 5 million?
The budget proviso, I think the statutes, it's 2.5 million.
Okay.
But we've had a budget proviso since, I believe, 2022.
So what would the cap be then?
I think it should be.
This bill requests
5
it to
million.
be statutorily moved to 5 million.
Right.
Yes.
Oh, okay.
So not above that.
Okay. Would this bill allow the legislature to continue to increase the cap or get rid of the cap?
I believe so. I don't want to misspeak on behalf of the agency. I would say that we expect as many as 5 to 10 conditions to be added to the RUSP in the next handful of years. It does cost anywhere between $120,000 to $200,000 per condition we add. And so if you look at the fiscal note that we've submitted over the last several years, I think our spending was around $4.6 million last year. Adding a new condition this year, following year, we really will be up against that cap. And a lot of those
back
costs.
to a proviso? To increase the
Potentially,
cap,
yes, but we just don't want to go backwards necessarily. We
Sure.
have a lot of things that are in place as a result of the proviso that we'd love to maintain.
All right, thank you.
Yeah.
Committee further questions? Representative Steens.
Thank you, Mr. Chair. Thank you for your testimony. Quick question. You said Kansas was one of only 3 states.
Yes.
In those other states, does insurance pay for a newborn screening? And then my second question is this every newborn that gets screened, or does it depend on like the parents can't afford it or something, along those lines?
Great
Thank you.
question. So I believe, and I don't want to misspeak on the medical assistance fee fund, but I believe that's a fee that's paid in by insurance organizations that operate in Kansas. And so there are 4 priorities that come from that, and the newborn screening fee fund being one of those. So it's not any additional money that fiscally impacted there. It would just be allowing us to have a larger piece of that funding pool that's already available. Next question. So it's newborn screening is free. The blood spot screening is free to any family. And so we're an opt-out state. So unless a family requests that they not have a screening done on religious purposes or other reasons, we perform that screen, and there's no cost to the family for that.
Representative Oropesa.
Thank you, Mr. Chair. Thank you for your presentation and your testimony here today. Would you object to adding all healthcare providers onto this bill in reference to like midwives, nurse practitioners, physician assistants?
Yeah, no.
For screening
We would not
purposes?
object. We work quite closely with midwives. We're establishing contracts with them to support reducing barriers for families who are in rural areas and aren't able to get back in for a repeat screen. So we're contracting with some so that we could call them and they could go out and collect. We do have some midwives that are able to do collections of blood spots. So yeah, I think we're open to anyone who's able to get a screen. We see the fiscal impact, the long-term impacts of that early identification versus later identification on the healthcare system, the school system, and those things as well. So
Okay, thank you.
Just clarification on that, but they already have that ability, and you already have that ability to work with those folks.
yeah, absolutely.
We don't need it in
no,
law.
it wouldn't restrict them. We do work with midwives, other providers who we have birthing facilities, but also those called collection facilities, so they can come in and collect the blood spot specimen and send it to our state lab.
I just want to make sure
Yeah,
we don't need
yes.
an amendment or anything to allow that. They already have that ability.
The bill states it's very specific to institution and physician.
Yeah, I think, again, when this legislation was originally, I think, drafted in 2020, I was just coming on, so I wasn't a part of that. We are totally open to, would be a proponent of that as well to include them, but they're certainly a part of our screening process now, midwives and any other practicing clinician who's able to collect a screen and send it in.
Okay, very good. Thank you. Yeah. Representative Howell.
Thank you, Chair. I will just also kind of follow up and kind of express a small amount of concern also I was going to also ask, just because line 15 in the bill specifically names physicians, hospitals, public health nurses, and then it does use the phrase "and the public" concerning conditions identified by the secretary. And so it is somewhat specific in who they work with in the intensive educational program. And so it did give me cause for concern that it didn't list nurse midwives or lay midwives, or like particularly the Amish, or for example, things like that. So now granted, perhaps it could be under the umbrella of the public, but so especially with free testing and things like that, I just wanted to make sure that it is inclusive. So and that's what I was going to ask you about.
Absolutely. I think we typically use the term birthing providers to encapsulate whether you're a facility or an individual, a midwife who provides birthing services and can screen. Not all midwives screen. If they're interested, we do get them the equipment. We do training with them on how to collect, shipping services and transit services to get that specimen to the state laboratory. But yeah, our program operates currently, it's all inclusive. So it's not restricted to any one facility or individual type.
Thank you for that. Representative Rivas.
Yeah, thanks for coming. Appreciate your testimony. I was just going to get a little clarification. So on the RUSP screening, there's core conditions, there's secondary conditions, but you talked about follow-up screenings. So are pretty much all screenings, whatever's necessary? If there's a follow-up, is that all part of this being included?
Yeah, so there's a lot of conversation federally going around primary and secondary conditions. I think there's a misnomer that we don't screen for as many conditions as some other states, but they include secondary conditions in their count. However, through our primary panel, we do identify those secondary conditions. We just don't adjust our cutoffs to ensure that we don't miss any. So we don't want to misrepresent that number. And so we screen for the core conditions that are on that panel, but also through follow-up and referral to specialist services, they identify those secondary conditions as well.
Okay, thank you.
Okay.
Committee, further questions? Seeing none, thank you very, oh, I do have one for you. I had called Ashley the other day about, I don't know if she clued you in on that, about the cost of the food.
Yes.
And so what percentage of that 5 million is used for that, or is it totally?
It's not, so I think when the legislation was originally written, it was everything was kind of mixed together. And so currently, what we look at is that long-term monitoring and support through treatment and treatment products is what we kind of would consider our special healthcare needs program. And so that program does receive state general funds specific for PKU formula in the amount of about $199,000 a year. And so that provides the treatment products. There's also Title V MCH funding that provides supports for medical equipment and devices, treatment, copays, transportation, respite care. Those things are all operated through our special health care needs program. So this specific $5 million really goes towards the operations of screening and then the follow-up after the fact and supportive consultation contracts with some of our specialist providers.
Very good, thank you for that. I just wanted to make sure that that wasn't half the budget.
Yes.
You know, I didn't know if it was even included in there until I read the bill. Okay, very good. Committee, anything else? Thank you very much.
Thank you.
Committee members, I might mention for two of you that are interested in that, we are going to work this bill tomorrow. So if you do have an amendment that you want to put together to clarify that, we'll certainly entertain that during tomorrow's working of the bill. Okay? Where are we now? Heather Braum, welcome to committee.
Good afternoon again. Again, I'm Heather Braum, Senior Policy Advisor with Kansas Action for Children. And thank you for the opportunity to share our strong support for House Bill 2399 and the newborn screening program. Rather than diving into the technical details of the bill, which you've already heard about, I want to focus on the newborn screening's impact upon the 34,000 Kansas newborns each year and on their families. Some of these babies look perfectly healthy at birth, but they could have a hidden condition that can only be detected through the newborn screening process, while the conditions are still more easily treatable. Not treated early, these conditions the program screens for can result in lifelong, severe, and costly medical conditions, physical and/or intellectual developmental disabilities, and even death. When these conditions are caught and treated early, children can have a very different outcome in life. The miraculous impact of screenings and early treatment now for cystic fibrosis is but one example. The benefits of the newborn screening program are immense. It gives parents peace of mind, triggers early interventions and treatments when needed, gives babies their best chance at healthy development, automatically double checks positive results, lowers medical costs over a child's lifetime, and connects families with providers and specialists and support. But most importantly, kids live to see adulthood. The program prevents death and saves lives. As an expert on a 2021 National Conference of State Legislatures podcast declared, I would say that newborn screening is probably the most time-sensitive function of state government. House Bill 2399 increases the program's budgetary cap to $5 million, as has been in the last several years of budget provisos. But I would strongly urge this committee to consider removing the budgetary cap entirely. Making this change does not mean that the program's budget will run into the tens of millions of dollars. Instead, removing the budget cap gives this critically important program for all Kansas newborns the flexibility and sustainability into the future, including adding more recommended screening tests as they become available, responding to higher lab costs, and broadening family outreach and support. without needing to repeatedly return to the legislature to request those additional budgetary cap increases through legislation or budget proviso. Kansas newborns are our future, and we should all be doing what we can to support the small but mighty newborn screening program that plays an important role in helping each Kansas newborn get off to a great start in life. Thank you for the opportunity to testify in support of House Bill 2399, and I'm happy to stand for questions at the appropriate time.
Committee questions of Heather? Seeing none, thank you very much. Okay, committee, I'll bring your attention to written-only proponent testimony, Carrie Padding, Allison McCain, Karen Brayman, and Dr. Dina Hubbard again. So with that, we'll close the hearing on 2399. Committee, we will work Senate Bill 88, which, yeah, I'm doing Carly's job for her. What is going on here?
Thank you, Mr. Chair. Committee, Senate Bill 88 concerns the state long-term care ombudsman and requires them and any regional ombudsman to receive training in memory care.
Committee questions of Carly about that. Representative Ellis.
There was an amendment? There was an amendment?
Well, there was discussion of an amendment, and after further discussion, that would have gutted the entire bill.
Okay, thank you, sir.
So after looking at it in consultation with my learned vice chair here, we're not going to run that amendment.
Thank you, Mr. Chairman.
So it is exactly the same as we heard it the other day. Committee, further questions? Seeing none, I would entertain a motion to pass out. Representative Bueller?
Mr. Chair, I move that we pass out Senate Bill 88 favorably.
And a second? A second by Representative Pezzo. Discussion. All in favor say aye.
Aye.
Opposed? Same sign. Bill's passed. Okay, committee, just a little cleanup work for tomorrow. We're going to continue our aggressive schedule. We will hear Senate Bill 175 tomorrow, but we will work the 4 bills that we just heard today, and if we have time, we will also work the MHIP bill. So that will be tomorrow's agenda. 2386, 2250, 2397, 2399, Senate Bill 126, and if we get time, we'll work 2236, House Bill 2236. Okay? All right. Thank you for all your hard work this week. I know we've been grinding it out, but we've got to get this done, and it'll be a lot easier next week if we get this done this week. So thank you.